So I want to welcome everyone to our citywide grand rounds for this month, and it's great to see everyone here. Thank you for making the time. This is jointly sponsored this month by the University of Toronto Department of Psychiatry and Unity Health, St. Mike's in particular. And so we would thank you for being here today. Before we begin, I'm going to read our land acknowledgement. I want you to situate yourself and take a moment to think about the land and around you. We recognize many Indigenous nations that have long-standing relationships with the territories upon which the sites the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge the presence of the traditional treaty of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe and Chippewa, and Haudenosaunee and Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we're grateful to have the opportunity to live, work, and gather in these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not fully capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. So thank you to listening to this. This is going to be a wonderful presentation by Dr. Rizvi. And an evaluation link is going to be sent to all our attendees following your presentation. Your feedback is always appreciated as we continue to work to improve things. And the next citywide grand rounds is the Vivian Rakoff lecture. So please consider attending that. Now I'm going to pass it on to Dr. Dang, who is the Deputy Chief of Psychiatry at the Unity Health St. Mike's. And so Dr. Dang is going to do the welcome and the introduction. Thank you.
Thank you. So unfortunately, Dr. Karen Shin couldn't be here, so I'm the Deputy Chief, and I'm so pleased to be able to introduce our speaker today. Won't hesitate anymore. Dr. Sakina Rizvi is the relatively recently named chair of the Arthur Sommer Rotenberg Suicide and Depression Studies program here at Unity Health Toronto St. Michael's Hospital. She's Associate Professor of Psychiatry at the University of Toronto. Her research focuses on understanding the neurobiology underlying suicide risk and treatment-resistant depression through advanced neuroimaging techniques such as fMRI and PET. In addition to her neuroimaging work, Dr. Rizvi develops and evaluates novel psychotherapies for suicide prevention, depression, and trauma resilience, with the aim of translating these therapies for use in hospital and community settings. She is also deeply engaged in participant-centered research, collaborating with persons with lived experience of suicide risk and national partners to develop effective suicide prevention studies. Her advocacy extends to mental health education, often using the creative arts to raise awareness. She led the Storybook Project, a lived experience short story collection on the impact of suicide, published in September 2021 as What It Takes to Make It Through, Stories of Suicide Loss and Resilience. So without any hesitation, I'd like to pass it over to Dr. Sakina Rizvi for a fantastic, I'm sure to be a fantastic talk.
Thanks so much, Kian, for that really generous introduction. Let me just get my slides ready here for you all. So I'm really pleased to be here today with all of you, even though I can't see you, but you're somewhere in the galaxy of Zoom. I'm really also pleased that we're having more suicide content this academic season. We heard Dr. Mark Sr.'s fabulous rounds in the fall, and I'm very excited to talk to you today also about the ASR chair initiatives that are going to be coming out over the next 5 years that I'm going to be pushing out, really focusing on both long and short-term approaches that would integrate things like neurobiology, intervention, and education. But before we get going, some of you may not know what the ASR is, so I'm just going to let you know about that. So this is an endowed chair at the University of Toronto. It was created in honor of Arthur Sommer Rotenberg, who was a physician who died by suicide. So this chair was established in 1996. It's been held at St. Michael's Hospital ever since. And leadership, our fearless leaders here who are very important in the field have led the way in the last 25 years. So Dr. Paul Links and Dr. Sydney Kennedy. So while this is primarily a research chair, we do also focus on clinical support. Another thing that's a really big value of the ASR is education, particularly connecting with the public and the community. I really do think it's important to have these targeted suicide programs and targeted suicide chairs, because as it stands, every 40 seconds, someone's still dying by suicide. And in Canada, our suicide rates haven't really that meaningfully changed in the last 10 years. I often talk about how suicide doesn't happen to an individual. This is something that happens to communities. It happens to generations of people. So it's so important that we have a focus just on suicide as well. So what do I mean when I talk about suicide? This may sound obvious, but we don't have suicidal feelings. We have suicidal thoughts and suicidal behaviors that are in response to some intense emotional pain. So it's not about, I want to die. It's about, I don't see an escape out of this pain that I'm in. And when we look at the research, it's very clear there's a lot of biopsychosocial cultural factors that are associated with suicide attempt risk. So if there's one thing that you're taking away from today, is that suicide is not one thing. Okay, if we look at social factors or socio-demographic factors, age, second leading cause of death in youth, psychologically, mood disorders, cognitive alterations. Biologically, we're seeing, brain volume activity changes, inflammation. However, despite all of this amazing research that's been done, this is the reality. If you look at depression, for example, over 50% of people will have some level of ideation from, I feel like life's not worth living, to have a plan to kill myself tomorrow. 20 to 25% of those will actually go on to make a suicide attempt, and 3 to 4% will actually die by suicide. We're not very good at understanding who this 20 to 25% is. It's still not fully characterized in a way that's going to really help us clinically. So it's such a clinical challenge when someone is in your office and they have ideation and knowing, is this someone who needs additional intervention? Are they more at risk of suicidal behaviors than someone else? So what do we do in this case? And I really love this framework from the National Suicide Prevention Task Force in Australia, because it really emphasizes the need for both longer term and more immediate solutions. So on the longer term, maybe policy responses to more immediate things like needing to have a system that's responsive to someone who has suicide risk right now. So at the ASR chair, this is kind of the direction we're going in. And another way of looking at this is starting with the micro and going to the macro, which I actually also think overlaps with the longer to shorter time frames. So I'm going to take a little bit of a whirlwind tour of these 4 levels and what we're doing in brain biology, developing new interventions and community work, as well as clinician training. So I'm going to start off with brain biology. There's several areas of interest here, including the irritability research that's being led by the fabulous Dr. Katie Dunlop. I'm going to focus on physical pain processing, and you're going to understand why in a minute. So when starting a project, I like to start with theory. There's several suicide ideation to action frameworks, and I would say that we still need to know more. I would say these frameworks are still evolving, but there's a few main ones, and they have some commonalities. They have some, they diverge in some ways. But the commonalities are that they propose that ideation is incited by things like not feeling like you belong, so social isolation, feeling like you're a burden on other people, but that these things in and of itself are not enough for someone to act on those thoughts. So what would be required for that is this construct called capability for suicide here. And this was created to explain why ideation doesn't universally lead to attempts. It's characterized by 3 things. So you have means, access, so just practical. The other piece is not having a low fear of death by suicide. And third is having a high physical pain tolerance. And these things would be needed in order to override your instinct to survive. Now, that physical pain tolerance could be something that's more genetically mediated. It could be acquired over time based on repeated painful events in a person's life. The thing that's interesting here is that pain tolerance has a very established neurobiological circuit. So that became something that we were curious about. And well, what's the neurobiology then of capability for suicide? And if we look at the behavioral data, and this is going to be data where someone's experiencing a pain stimulus like an electric shock, or they put their hand in cold water. And I would say that the evidence is, is fairly consistent here in that people with a suicide attempt history tend to have higher physical pain thresholds. So that's the level of stimuli that would be needed for them to perceive that pain is there. They also have higher physical pain tolerance. It's a bit more, self-explanatory. This is just the max level of pain you can tolerate. But what's interesting here is that you tend to have a dichotomy where there's increased physical pain tolerance, but decreased psychological pain tolerance, or psychache, which in and of itself is a pretty strong predictor of suicidal ideation. You also tend to see decreases in subjective ratings of intensity. Now, if we look at this on a neurobiological level, I'm going to break this down in a very simple way. If you have a pain stimulus, you stub your toe, it goes up your spinal cord and gets into your sensory cortex, where you just perceive that something happened. There was a pain stimulus. However, you also have this other network pathway where it's going through the insula up to your prefrontal cortex, where this is like your affective and cognitive modulation of what has just transpired. And so you have feelings, you have thoughts about what happened, about this pain stimulus, that are actually going to impact your perception of how aversive that it was. This figure over here on the right is basically saying the same thing. These light brown areas are more like these sensory pathways. The dark brown are more of those cognitive affective modulatory pathways. So Xijing Wang was a master's student working with me, and her project was exploring the neurobiology of capability for suicide. So she included in the study people with depression and suicide risk compared to non-psychiatric controls, and looked at, she put their hands in a vat of like maybe 2 degrees Celsius water, and found that just behaviorally, that self-reported capability for suicide, the higher that was, the higher your pain tolerance, the higher your pain endurance, the more pain you could endure, and the lower your subjective intensity ratings were. What was interesting here also is that the more suicide attempts you have, the lower your pain tolerance and the lower your pain endurance. So there's a whole host of theories there that gets into subtypes that we can talk about in the question period. But when she looked at resting state scans and looked at correlations with suicide capability scores, what she found was that there was correlations in brain areas and connectivity in areas that were important for how aversive a pain stimulus is perceived, pain affective regulation, as well as pain perception. It's important that these markers were not found in the non-psychiatric controls. It was only specific to the MDD patients. So this was an indirect finding, right? This was a resting state study. So the follow-up was, well, what if we actually look at pain processing in the scanner when someone's actually experiencing it? And so in comes Jennifer Ma, who just defended her thesis successfully on this project back in January. And in the study, we got this contraption from the US, and basically what it's doing, it's delivering a pressure pain stimulus on the leg while the person is in the scanner. She included people in the study that had a suicide attempt history versus no attempt history, as well as non-psychiatric controls, and also controlling for levels of ideation. So basically what she found over here on the left is that if you look at the group of people with suicide risk, they appear to have greater activity in areas like the anterior cingulate cortex, dorsolateral prefrontal cortex, anterior insula, that are important for the affective and cognitive modulation of pain compared to non-psychiatric controls. Where I think this also gets even more interesting is when you break this down by group. So if on the right-hand side here, this suicide attempt group, they're in these areas in the anterior insula, anterior mid-cingulate, and the dorsolateral prefrontal cortex, we see pretty moderate effect sizes here, where the suicide attempt group seems to actually have lower activity in response to pain than the ideation group. What's interesting here to me is that you seem to have this hierarchy where the ideation no attempt group has the greatest activity to pain. The attempt group is in the middle, and then there's the non-psychiatric control. So it suggests potentially that people with ideation only and no attempt history still have this reactivity to pain that the people with a suicide attempt history don't. So we're currently still working on this. Of course, this is preliminary data, and so we're working to boost the sample size of this study. But really, why are we looking at biology to begin with? I really think it's important to have a comprehensive biopsychosocial model of suicide risk. By no means do I kind of follow like a purely medical model of suicide risk. There's clearly other factors at play. However, I do think that biology is part of it. And there's things that we can resolve on a biological level that sometimes we can't see on a behavioral level, or even even just based on clinical presentation, because we can't get at that nuance. So that's why I also think that, based on that, it could also really help with that risk stratification piece, especially if we can start to develop behavioral proxies for the brain alterations that we're seeing. I think it can also really be helpful for targeted interventions for suicide risk. So this could be neuromodulatory targets. In this case, if we just take pain, for example, like I mentioned, the different pathways that are sensory versus cognitive affective. Well, if we can establish that actually it's more the cognitive affective modulation of pain that might be contributing to suicide capability, well, that's something we might be able to target with a psychotherapy. But that's a nuance we wouldn't have been able to understand unless we had that neurobiological data. So that brings us to interventions, and I'm a psychotherapist, so that's the intervention development that I focus on. Now, there's been a pretty strong movement towards developing targeted suicide psychotherapy, and I think that's for several reasons. One is that the meta-analyses that have been done on the conventional psychotherapies typically actually have small effect sizes on suicide attempt risk, which I was actually surprised to see myself. It's actually even worse when it comes to youth. And so I think that this move towards targeted suicide psychotherapies has several benefits. So one, I think it addresses suicide directly. So I think in that front, it can be very destigmatizing in and of itself. Clients can often be afraid maybe to even mention suicide risk, or they might fear that their clinician is fearing that conversation. So it brings it out in the open. It allows a narrative to actually start to happen. Two is that these interventions are also more based on theory and research and what we know might be unique challenges for someone with suicide risk. For example, I mentioned that social disconnection can be something that incites ideation. Well, there's a therapy called engage therapy that's been developed specifically for elderly with suicide risk, focusing specifically on social disconnection. So that's an example of how I think that these targeted therapies can work. I think they also give us other measures to track. Really, monitoring suicide risk is really not just about suicidal thoughts. So I think this gives us other targets to measure over time. So how frequently are you engaging in your coping behaviors to manage your suicidal thoughts, like we had talked about? If not, let's explore those barriers. How frequently are you using your social network? So there can be different ways that we start to track someone's suicide risk. Now, there's also been a push towards brief therapies, and these are things that could be more easily implemented in hospital or community settings. There's really no one size fits all. So I think it's going to be likely, even conversations with my other suicide interventionist colleagues across the globe, that you're going to need several of these in your toolbox. Much like, you might know CBT and DBT, you might know different types of therapies under your belts. You might need several of these because they're targeting suicide risk in maybe a little bit of a different way. What's great about them is that they can be integrated into any therapy modality that you're doing, even if it's longer term. And on average, I would say they're mostly about 1 to 5 sessions. So I'm going to take you through one that we developed here called Brief Skills for Safer Living that was developed with Dr. Yvonne Bergmans and Dr. Alexandra Lalovic. This is a single 90-minute intensive therapy session. It was adapted from Yvonne's Skills for Safer Living 20-week group therapy that she's developed over the last 20 years. So we create this in response, to the COVID pandemic. We started getting a lot more calls of people who needed support. not being able to access care, not knowing where to send people. So we're like, okay, well, what are we going to do about this? So I, approached Yvonne. I was like, well, what if we do your 20-week group therapy in a single session, which is ambitious, but bear with me, and there is precedence for this. This intervention is based on the same theory and goals as the broader group therapies. So the idea is that once a person can accept the possibility of choosing to live or not die right now, they're going to be more likely to do the things that are going to reduce their suicide risk. And a big piece around this intervention is that what we're trying to do is get people to engage more in those things that are going to reduce their suicide risk, those safety interventions, even if suicidal thoughts are present. So that even if is a very, very big part of this intervention. So what are we doing in this 90 minutes? So we have three aspects of this intervention. There's a narrative piece where we're really just trying to understand the suicidal experience, skills that are targeted to living more safely, an enhanced safety plan. So, we will derive like a plan of like what you're going to do when you're in crisis or when you're not in crisis to support yourself. And then we're going to say, okay, now tell us why you're not going to use this plan. And then we're going to use solution-focused strategies to engage them on ways to overcome those barriers. So to take you a little bit through this narrative piece, we start off with three questions. What does suicide mean for you? What would it end? What's kept you alive? How do you know when you feel safe or unsafe? What we're listening for as a therapist is, can they identify their emotions? Do they understand how their suicide fluctuates in intensity? Are they aware of their strengths? Do they know what their early warning signs are? And do they recognize what their social supports are? And so what we're trying to do is create this narrative to make a connection between their suicidal thoughts as a response to painful emotions. Also inquiring about, when did the thoughts start? What was the context? Are these thoughts relieving? Are they distressing? How and under what conditions do they fluctuate in frequency, duration, intensity? And so once we have that narrative, we have a better understanding of what skills we need to target. This is not a manualized intervention. I would say it's more modular. So skills are more tailored to what a client needs. But there is a couple that we do with everybody. And I'm going to highlight one of those tools. It's called the scale of intensity. And what this scale of intensity does is we're trying to track the intensity of ideation. And based on a particular level, what are the feelings that you have there? What are the early warning signs? How do you know you're at a 3 to 4? How do you know you're at a 7 to 8? What are the strategies that you can use when you're on your own and no one else is around to support yourself? What are the networks you can reach out to support yourself, who not to call, maybe also? And also we break this down by who's good for emotional support, who's good for practical support, who's good just to distract you. So people might not be good at all three, right? But if we feel like all people have to be all three to be considered a resource, then we actually might be missing out on a really big network of people who can be supportive. So the idea here is that we're really trying to track the ideation before it gets to the point where your prefrontal cortex is offline and it's a lot more difficult to support yourself. And even if you're in that stage around your prefrontal cortex is offline, what are you going to do, right? Because your strategies are going to likely need to be quite different at that 8 to 10 phase than it is at a 5 to 6. So the idea is that we're trying to help people strike when the iron is cold, as Yvonne would say, before you can avoid even going into your crisis zone when it's more difficult to keep yourself safer. So we tested this out across Canada in 77 people amongst adults with suicidal ideation. There was a very low bar for entry. It was like, do you have suicidal ideation? I don't care what your diagnosis is. If you have substance use, that's fine, as long as you don't show up to the session inebriated and you can understand what's happening. We wanted this to be very generalizable. And we did this completely remotely. I think this is very, very important because people often exclude people with suicide risk from studies. They feel like they can't do it safely. The research does not support that at all. And this is a group of people that really does need to be included in these research studies. So this study, I would say, really supports the fact that you can do this work even remotely if you have an effective suicide safety protocol in place. The other benefit of this, doing this over Zoom, is we were able to access people even in rural areas of Alberta or Newfoundland that wouldn't have access to care otherwise. So that was a big goal for this intervention, was that we want to get people rapid care that's accessible. The other piece was we followed people up with 1 week, 1 month, and 3 months. And what we found at 3 months was a significant drop in suicidal thoughts. But as I mentioned, suicidal thoughts is not the only thing. What we were actually more interested in was, could you keep yourself safer, even if the thoughts were there? And based on the qualitative and quantitative feedback, 77% of the 77 people said, yeah, I feel more confident, I can keep myself safer. And that was after a single session. So what might be different then about these targeted suicide psychotherapies? Well, in the context of brief skills for safer living and our qualitative and quantitative data that we got, the feedback we got, people felt like, you know what, like I feel like I can track when I'm getting, when I'm starting to escalate more, and then I know what to do and I feel more motivated to do it. I think that another piece around these interventions that, in talking with my colleagues, is that this narrative piece is really important. Often people have suicidal thoughts and they think there's just something wrong with me, rather than reframing it as, oh, this is actually a symptom of something. This must mean I'm having suicidal thoughts. It must mean I'm overwhelmed by something. So it's a bit of a reframe there. Actually, not a bit of it's very much a reframe. I also think that the therapeutic alliance is probably more important in this context, also based on the suicide theory we talked about, that social disconnection can be more connected to ideation. And the research does show that therapeutic alliance moderately is associated with ideation out to 2 years. So I do think that plays a big role here as well. So where are we going with this? We are going to be doing a national RCT to ensure that, we're not just nice people and this intervention actually works. And so that's hopefully going to be starting in the next 2 months. So also, if you have people you would like to refer, send them our way. We're also going to be developing, which we're actually already in the process of developing, a pilot to run this in the emergency department at point of care. So this is important because we're going to be able to assess the impact on patients as well as representation rates. We're also curious as to why does this even work? We're looking at mechanisms of action. So we're working with Andrea Diaconescu, with our graduate student Angelique Kuriak, to do some computational modeling of some behavioral measures that we're testing. And then Molly Hyde is a PhD candidate who's looking at this from the anhedonia reward processing angle. So clinicians are not the only solution though, right? Okay, so let's expand outward in our circle to the community, particularly amongst caregivers who, in my opinion, they really are the true first responders. They play such a huge role in that caregiving piece for crisis intervention, being a support, but they often have their own experience of their loved one's suicide risk, whether it's their own feelings of shame, attitudes towards suicide, and not feeling like they have the tools actually do this, because really prepares you in life to be able to manage your loved one's suicide risk. So they often have reductions in their own mental health. So we have a community advisory committee of people with lived experience who advise us on what we should be researching. And they said, well, caregivers actually really need a lot more support than they're getting. And so what we did was, as a group with the CAC, we did the systematic review of existing gatekeeper training programs. And what we found was that, these existing gatekeeper training programs can increase confidence and self-efficacy. The behavioral changes are maybe a little less robust, or they actually weren't reported. But what was crucial from the systematic review is that people with lived experience rarely included in program development. And these programs actually don't target the unique needs of caregivers. So the CAC said, we want a caregiver program. So we said, okay, let's do that. So we started to develop the Family and Friends of Individuals with Suicide Training First program with the generous support of Canadian Association for Suicide Prevention and the Mental Health Commission of Canada. I really want to stress that this study is done with our CAC members as co-investigators at all stages of the project. They are major contributors at every decision phase. And so first phase was we did a Canada-wide needs assessment on what would you want in a program like this. And then phase 2 would be development of the first program and then actually piloting it. We're pretty much almost done phase 1 and 2. And I'll tell you a little bit about the National Needs Assessment. We're targeting 40 interviews across Canada. And what we're doing is we're trying to get a sense of what obstacles did you face supporting someone you cared about? gaps in support. What do you want this program to look like? And we were wanting to get representation from across 4 participant groups: people who have a history of suicidal ideation, people with a history of suicide attempt, people who identify as a caregiver of someone with suicide risk, as well as people who are bereaved by suicide. Another representation piece that was crucial for us is that we wanted to make sure we were representative across diverse communities. So our target was to have 50% of the interviews from 2S LGBTQ+, Indigenous, Black, and racialized communities across Canada. We're also aiming to have representation across all of the provinces and territories. So to give you a sense of the themes that came out thus far, not surprising, people feel like they need more support, emotional, practical, physical. How do you navigate the healthcare system? I don't understand these processes. I don't know what information clinicians need. But a big thing that came out was that racialized, Indigenous, and 2S LGBTQ+ participants have a very different experience in the healthcare system. I really want to stress this because discrimination was highlighted as a big barrier to getting effective care across Canada. Okay, so people talked about feeling dismissed. Assumptions were made about me. I had to dress more formally or use more formal language. One participant talked about having to bring their white male friend with them to feel like they could get the care that they needed. So it's really crucial here for clinicians to develop a more reflective practice around exploring your biases, participating in cultural safety training. This in and of itself could be a suicide prevention thing that we do. And I really do think that this is a moral imperative. So in terms of what people said they want the program to look like, education, of course, but things that popped out were also, I want to know about medication safety. I want to know about cultural aspects. I want to know about my day-to-day management. What does that look like? How do I assess safety? How do I navigate if they don't want to get help? The practical aspects around going back to school, life transition, self-care. How do I support myself when I'm having to support my loved one and it's taking up so much of my time? How do I become an advocate in the healthcare system? And how do I navigate resources, including non-police responses, which is particularly important for Black, Indigenous, and racialized individuals? Skills building. I don't really know what to do when my loved one tells me they have suicidal thoughts. How do I validate them? What do I do? What do I not do? But also, how do I speak about this to other people in my network when maybe this isn't fully my story to tell? So where we're going with this right now is we have a few more interviews left to do in French. As I mentioned, we're trying to aim for representation across Canada here. That will be done by the end of March. We're currently working with our community advisory committee to have this program developed by the end of April 2025. And then we are hopefully starting our pilot in May 2025, and that will be locally in person in Toronto, as well as virtually, well, actually GTA in Toronto and virtually, as well as a virtual session across Canada. So that leads me to clinician training. That's the last thing I want to talk about for today. And I think that this is something that is also incredibly important. Suicide work is really hard. It is a top stressor for clinicians. We often don't get specialized training in this area. And so it makes sense why clinicians often feel like I don't really feel confident assessing suicide risk. And then even if I do know how to assess suicide risk, I don't really know what to do afterwards. And so there can also be reservations around having to do crisis management or call 911 or hospitalize someone. And then there's also the fact that it's a tragedy when you lose a patient to suicide, right? And managing all of that in and amongst professional liability risks, a perceived risk of a patient's suicide or like suicide itself contributes to exhaustion and depression among psychiatrists. So suicide intervention is very hard. And I want you to consider this. Where other healthcare professionals experience the death of a patient as an unfortunate yet sometimes inevitable consequence of an illness, mental health care providers often experience the suicide death of a patient as a personal therapeutic failure. So this can increase self-doubt, being more cautious managing suicide risks. So the research shows that can lead to more, risk assessment admissions and voluntary admissions. This ranges from like 12 to 50% of clinicians. So, the countertransference is very real. We talked about this at Sinai Grand Rounds last year, and so I wanted to bring this back as Dr. Rodney Sonam, who's the late Rodney Sonam, was an amazing therapist there, and he published this in 2000, and I'm putting this up here because it's still true 25 years later. It's that because the patient in crisis characteristically presents feeling overwhelmed, confused, needy, there's a sense of urgency, helplessness that can impact a resident therapist's intervention. So common countertransference reactions can be, assuming omnipotent control, grandiose rescue fantasy, passivity. So we can have over-involvement, over-responsibility, role of savior. And this really plays out with recent data showing that clinicians have instant countertransference reactions towards patients with suicidal ideation. And how does this actually maybe impact treatment recommendations? Well, if you look at the study that assessed clinicians' self-report response to working with suicidal clients, they also measured their ability to self-regulate emotions and treatment recommendations. And what they found was there was a direct effect of how a patient's suicide ideation impacted the clinician negatively and whether to intensify treatment. The only other thing that in this study that contributed to whether to intensify treatment was a clinician's own ability to regulate their emotions. So if you notice, ideation over here did not contribute to that, whether to intensify treatment. So in other words, the clinician treatment recommendations and decisions were being more emotionally informed. And that association pattern is stronger among clinicians that have a greater emotion regulation difficulty. So it's not really observed as much for clinicians with little emotion regulation difficulty. So I think that this might sound a little grim, fair enough, but to say that all of these skills can be learned, right? I really do believe, again, suicide intervention is hard work. And clinicians deserve to be supported in the best way possible when doing this work. And I think that there's a better way to do this with emotional safety. I know Dr. Javers here at CAMH is really doing some great work around risk assessment training and residents coping with patient suicide, which is amazing. And for clinical trainers, there's definitely more active training techniques that we can use. I can tell you that, my own training that I had with Dr. Berkman's, and, she's like the suicide interventionist in Canada. So I was very, very fortunate. And having that weekly supervision between her, Dr. Lalovic, and I for basically weekly for almost 2 years was essential. All we talked about was suicide intervention. It was essential for me to be able to do the work the way I'm able to do it now. And as, care providers, you can't do this work alone, right? It is too hard. So it's important to have resources to support yourself. I also think it's important to ground yourself. You have to know your personal rights and how to set compassionate boundaries. Some of you might scoff at that, but I can tell you from training, psychologists on suicide intervention in private practice, and we've developed a trauma resilience program for healthcare workers to deal with the immense amount of trauma they deal with in their jobs on a daily basis, that these are things that are always an issue. So maybe you're the unicorn this doesn't apply to. However, this is something that's a really big deal. But personal rights being like, I have a right to have needs, I have a right to make my own opinions, I have a right to be scared. And being able to set those compassionate boundaries, all of this really does help us stay in line with what our role as a suicide interventionist is. Okay? It's not to take away someone's choice. It's to help them create a path to understand their suicidal thoughts and navigate their suicidal thoughts and provide crisis intervention if and when needed, right? So all of this is going to really help us to give from the surplus, not the core, not over-identify with clients. It's very much that Carl Rogers as if you're with someone, not the same thing as you are. And I can really tell you that the stress of working with suicidal clients will really test the fault lines if these boundaries are really porous. So one thing that I'm really excited about through this chair is to create more targeted suicide intervention training. So look out for that in the next year. We're currently trying to optimize that with some medical education experts that know a lot more about this stuff than I do, and also going through the CPVD process. So watch out for that as well. So there's also other ways, I would say, to get education. And I think that understanding the lived experience is crucial to that as clinicians. You can't ignore that. And so through the ASR, statistics are also, nice graphs, all that stuff, but it's not really what people relate to. So at the ASR, we really try to take a different approach to sharing stories instead of statistics. And we have run expressive writing workshops, documentary screenings, theater performances. But this ASR labor of love, it really was, we all kind of did this in our spare time, was this published short stories book of people impacted by suicide risk, and they found a path to healing. And this is really raw stories. My goal here was to give people a platform to tell us what you experienced, and to also have a pathway to find healing in that writing as well. I just find that sometimes the content that's out there can be very sugar-coated, and we wanted something that was very raw. We did only edit these stories for, based on safety guidelines that, Dr. Mark Sr. talked about in the fall. But aside from that, this is their voice. And the only other thing that we added at the very end was a few essays on biopsychosocial, predictors of suicide risk, what to do if you're a caregiver, what to do if you're going through suicide risk yourself, and also an essay on suicide bereavement. So that's something that we were very, very excited to publish. So to bring this full circle, I hope it's very clear, suicide's not one thing. And this is why we really do need these longer term and more immediate approaches to looking at suicide risk. And I think that understanding the complexity of suicide risk is really necessary for treatment advances, which is, I think, where some of that neurobiology piece comes in. But also, having these brief targeted suicide psychotherapies can provide rapid and accessible care. And then building community capacity. We can't forget our caregivers, right? For suicide prevention outside of professionals is essential. I also think that clinical training is a very low-hanging fruit. We can do a much better job at training our clinicians. And so I'm really excited to support that. And hopefully we can also make use of all the incredible expertise across the teaching hospitals here. And on that front, I do want to also highlight that U of T in and of itself is very unique in the level of specialized experience and expertise in suicide risk across the teaching hospitals. We do have a suicide hub. And within that hub, some of you may be familiar with the Aspire network of suicide researchers here in Toronto. That Aspire network is being led by Dr. Mark Sr. and Dr. Javer Zahir. And I don't know, Mark, if you are in the Zoom galaxy, if you want to throw that your snazzy new website in the chat. I really encourage you to learn more about what's going on at U of T, and hopefully we can have more rounds focused on the work that's being done across the teaching hospitals and the hub. So I do not do all of this work myself. And so I work with an incredible group of collaborators and generous funders, which is wonderful. I'm very, very grateful. Please get in touch. I love to chat with people. Let me know your ideas, any questions. Follow us on our socials in order to keep up to speed with what we're doing in terms of our events. We have some stuff on the roster this year. And yeah, that's it for me, and happy to take questions.
Thank you, Dr. Rizvi, for this wonderful talk, and really appreciate the very thought-provoking discussion and material that you presented. So let's go right ahead to some of these questions. There was a very interesting question on this question about Champrix or other medications that cause de novo suicidal ideation. What do you think of, what does this say about the biology of suicide? You talked about it earlier. Any thoughts on that?
I think that we have a lot to do biology. I can tell you that, like, I'm historically a depression researcher. And so when I started doing research in suicide, I'm like, I just kind of assumed that this research was being done, and it really wasn't. When I started doing this research, if you think those brain imagers out there, where there's like hundreds upon hundreds of resting state imaging studies in depression, there was not even one published in suicide at the time. So there's a lot that we actually don't know, even about the neurochemistry. So, I mean, I would say that, there's the PET work that's been done has mostly been, focused on serotonin. We have some PET work that's going to be coming out specifically looking at dopamine, but we don't have enough understanding, again, about the biopsychosocial piece or the biological piece, or the neurochemistry piece, to understand what's happening. This is exactly why I think we need to know, because that's also going to inform our treatments, our pharmacological treatments.
Absolutely. There was another very interesting question about the effects of clinician. You mentioned about a clinician emotional regulation and distress on intensifying treatment. There was a question about, is there any connection to treatment outcomes? That the more intense treatment, did it make no difference in suicide-related outcomes or improved outcomes? Was this looked into? Was one of the questions that was asked.
That's a very good question. I actually don't know like the immediate answer to that, but I will look into that. So whoever asked me that, please email me. But I do think it's interesting. But at the same time, I feel like when you talk to clients, and having done this work across Canada, I always start off asking, what's been your experience with therapy? What worked? What didn't work? So we're not repeating the same mistakes. And what's been your experience with talking about your suicide risk with your clinician? And there's been a pretty consistent, like, it wasn't so great.
Yeah.
Right. And so I can imagine that, like, they're often afraid that if I tell someone that I have suicidal thoughts, I'm going to get forms.
Yeah.
Or they're going to try to do something to take away, my voluntary freedom. So my guess, my hypothetical response would be that I don't think that it would lead to better outcomes, because also clients don't actually want to be in the hospital. Yeah. So it's like, as much as people are coming to the ER, they don't actually want to be there. Yeah. Yeah. And I think that that's an important thing for people to recognize. If there was somewhere else they could go, yeah, they probably would. So that's kind of my thought on that.
Thanks. There's another, very important question about, in terms of Indigenous communities, often there's a contagion factor. There was a question about how might your models that you're working on or apply to these types of group effects, or is there something you're considering in the future?
So particularly with our caregiver program, we do have some Indigenous partners that we're going to be working with. And I think that we have to make sure that anytime we're working with any group that's been historically marginalized, they have to be included, and they ideally should be leading it. But it needs to be very clear as to why they're at the table. It's not tokenistic. What's the goal here? Why am I here? And so we're going to be, that caregiver program might actually be something that they take and adapt for their own communities, right? But basically what we're trying to do is, like, here's a skeleton, and like this might be something that needs to get adapted to very much different communities. It could be different for the 2S LGBTQ plus community. It could be different for various communities. So I think that anytime we're doing any sort of work with diverse communities, we have to be very mindful with how we're doing that. So my approach has not been to be like, hey, like, we're just going to do this research on you. Historically, they have been incredibly exploited. They have every right not to trust researchers. And so you need to do a lot of relationship building and a lot of trust healing and building that before you can actually even start to do that work and even think about doing it.
Thank you. There's a question, I think, sort of clarification and feedback. The question was, do patients with self-harm have a higher pain tolerance and thereby a higher risk of completing suicide?
So I'm assuming with self-harm, you mean non-suicidal self-injury?
Yeah.
Yeah. And so there is evidence that is the case, that people with NSSI do have a higher pain tolerance. So I mentioned before that pain tolerance can be genetically mediated, can be dispositional, or it can actually be acquired. over time. So, and what they call painful provocative events. So, if you think of self-harm, you actually could be start to habituate yourself to a painful stimuli. Things like, complex trauma, repetitive trauma could also be things that could increase your pain tolerance. So yeah, I would say that would be the case. Now, I would just be cautious about saying that that's going to be the thing that increases their suicide risk. Like, we're still in the early days of exploring this, so I don't want to make that overinterpret that.
Yes.
But that could be the case. Yeah.
Okay. I think some people asked about the contact information. We can do that at the end. There was another very interesting question here. Is there any data on the effectiveness of urgent hospitalization and the trajectory in terms of suicide prevention?
Urgent hospitalization and the trajectory of like whether urgent hospitalization actually improves things.
Yeah, the long-term
Yeah.
trajectory. Yeah.
I mean, I think the answer to that would be that if someone is at risk and they're at imminent harm, it does help. But what is even more helpful after that is not so much just their inpatient experience, it's also what happens after that. It's also like what we found from our qualitative studies, like follow-up care wasn't always there. Like, so it's like if you go in and you come out, people often sometimes end up in these revolving doors. So I don't know how helpful that actually is. And based on from the feedback that we've gotten from participants, it's not. It's more the types of interactions that you're having when you're there. And also this idea of bringing in targeted suicide interventions. Are you getting a suicide intervention when you're there? So it's kind of like a holding place to kind of until your nervous system starts to calm. So, and you're out of immediate crisis. So I think it's more important in terms of what's happening when you're there versus, just kind of going in, because, that year after being discharged is the highest risk for suicide. That is there. It's like it's multiple times over that year after discharge.
Yeah, definitely things to think about for sure. There's a good question here as well about what are your thoughts on development of integrated psychotherapy, kind of incorporating substance use, trauma, and all these types of things together instead of working together sort of comprehensively. What are your thoughts on that?
Yes, absolutely. So trauma is something that we're particularly interested in, and this is something that we're trying to build actually across the teaching hospitals with Mark and Allison Crawford as well. And it's called Integrated Suicide and Trauma Therapy. And what we noticed in our Canada-wide study was a good chunk of the people who were there had maybe like at least a suicide attempt or two or more suicide attempts, but also had a very high prevalence of childhood trauma. And what we were noticing was that when we'd ask these questions of when did your suicidal thoughts start, surprise, surprise, it often started around that time. So that's kind of when then we would ask, have you ever had trauma therapy? And most people said, what's that? They didn't, have any of that experience. But also some of the trauma therapies don't work as well. Not that they don't, but they don't work as well if you have a history of childhood trauma. And so we decided that we wanted to actually develop a targeted intervention for people who have suicide risk and complex trauma. So that's something that's currently in development. We'll be piloting that in the summer, and hopefully starting this summer, but we're still in the development phase of the actual intervention.
Sounds good. So something to look forward to. It's a question that's a very, important question in many ways about what do you think about these models and things that you've worked on and treatment plans? What about people like educators, teachers, high school teachers, community leaders?
Mm-hmm.
Do you feel like it could be translatable to that space? And then there was a follow-up about questions about, do
Oh, Raj, I think you're frozen.
Oh,
Sorry.
sorry.
I think you froze for a second there.
Sorry, maybe I'll repeat it.
I thought that was me. Okay.
No worries. I'll repeat the question. Is there, in the high school setting or, for students, is there space for them to have some of these educational interventions? What are your thoughts on that? And then I think the initial question was on educators and other community leaders. Would the models that you've been working on be applicable to them, or could they be taught in some way, or facilitated in some way?
I think education is 100%. I think that education to the broader community is definitely an imperative. It's something that we really want to work on, actually, even in a public lecture series that we're hopefully going to be starting this year. But I mean, having targeted awareness within certain communities, like educators, like people who are high school teachers, et cetera, I think is really important. I would actually, for things like that, I would want to be collaborating with people who are more focused in youth. I don't have that youth expertise. And so that would definitely be a collaboration with some of my colleagues here at U of T, maybe to try to build that out. But I definitely think that this is something that's important. Yeah.
Great. There's a question about just generally about in terms of toxic drug supply, like fentanyl and all. There's lots of that talk going on. How do you feel that that there's an interplay on this? I mean, in terms of risk for suicide, and maybe you can
Yeah.
talk a little bit about that now.
So there's some coroner data in Ontario that I thought was very interesting. So if you look at the COVID pandemic, there was this huge increase, maybe 4 to 5, 3 times in the general population of ideation.
Yeah.
It didn't translate into increased, or supposedly didn't increase into increased suicide deaths. However, if you looked at this coroner data, if you looked at people who died from alcohol toxicity, it was pretty much flat over the course of the key periods of the pandemic.
Yeah.
People who died from substance use, huge increase. However, that increase was anticipated, but the rate at which it increased was more than what they would have expected. And I do volunteer grief counseling for people who are bereaved by suicide, and I definitely during this period had parents whose son had died. It was drug toxicity, but it wasn't clear whether it was suicide or not. I don't know how a coroner would know that, like immediately without any suicide note. So I still think that there is a relationship there, and I think even the fact of whether COVID actually did impact suicide rates is still, I would say, unclear based on that.
Wonderful. One more question. I think you touched on it, but I think they would want a little bit more info if possible. Is there any evidence regarding on the impact of community-based interventions, such as social work, case management, and other programs in terms of suicide? I think that's what they're going at.
Community programs like having a community mental health agencies, is that what you mean?
Yeah, I think maybe social work, case management. A lot of the community hospitals have, these social work managing cases, and maybe even freestanding centers, right? In terms of case management, in terms of patients, is there any evidence and research that helps?
Yeah, for sure. Yeah, for sure. And I think that anytime someone can get responsive care when they're at suicide risk, it can be helpful. But again, it depends on the kind of interaction that they're having. So that's going to depend on the program that they're in. But either way, yes, having like a responsive system that can address suicide risk immediately is very helpful.
Thank you, Dr. Rizvi. It's a wonderful presentation and talk, and very thought-provoking. I know some people wanted your contact information. I think they can reach out to Anne-Marie, and Anne-Marie can connect to Dr. Rizvi. That would be an easier way, I think, for a lot of people. I know it was on the last slide as well, but I think in the interest of time, that's probably maybe a good way. So thank you, everyone, for joining. It's a wonderful turnout today, so really appreciate your time. And we have another grand round in a month, and hopefully you'll be able to join for that. So thank you, everyone. Take care. Have a good weekend.